Well, good afternoon, everyone, and I want to thank the IHPBA for allowing me the opportunity to speak today regarding a topic that's certainly near and dear to my heart, which is the topic of ablation. And if anybody had just seen my session a little while ago on ablation, I'm pretty well warmed up. I think it was going to be Peter Lodge that I was going to be competing against here, so I'm a little bit intimidated by that, but I'll do my best. So I'm not going to go into this in too much detail. We're all hepatobiliary surgeons here, but just in general in the United States, about 160,000 new patients with colorectal cancer, or about 40% will develop metastatic disease, and about 20% will develop liver-only metastatic disease. And therefore, we also appreciate that the majority of patients who have metastatic liver-only disease are not candidates for liver resection with a curative intent for a variety of reasons. So we're going to hear a lot about the extended resections in a little bit, which is always great to hear. But again, and I put unresectable in quotes because I think that with modern surgery and advanced surgical techniques, we can certainly do a much better job than we did in the past. All right. So since most patients aren't candidates for surgical resection with curative intent, is there anything else we can do? And certainly one of the options then, rather than remove it, or in addition to removing, we can certainly destroy those tumors. And there's lots of different ways of destroying tumors. And throughout my professional career, I have done ablation from the beginning. So I've done cryo, radiofrequency, microwave, IRE, developing H-fire. And so I have a pretty good perspective on what can be done out there. I do want to tell a little bit really quickly about the story of ablation. Nope, messing that up. And starts with cryoablation. And so I did cryo back in the mid-90s. We did open cryoablations, one of my cases here, and then we learned how to do laparoscopic. They were the first laparoscopic cryoablations ever done. And again, we had pretty good effectiveness from a local control point of view in selected patients. Now this right here, I think, was a landmark paper by Weaver in 1998. So let's think back to 1998 in terms of liver-only metastasis for colorectal cancer. And what chemotherapy did we have? We had 5-FU, but we had really 5-FU only, or 5-FU leucovorin, or 5-FU levamisole. We didn't have the modern chemotherapy agents that we do have today, Folfox and FOLFIRINOX and antibodies and whatnot. And so now we have a select group of patients who have a metastatic systemic disease. At that time, we didn't have good chemotherapy as we do today, and with a local therapy for selected patients, we're able to achieve long-term survival or cure in about 20% of patients. That, for me, is absolutely amazing to me. And obviously, it talks a lot about the biology of the disease itself. But that's a really critically fact to know and remember. And I think this is one of the best papers ever published, other than Mike Passeries, wherever is my fellow floating around out there. So we moved on from cryoablation to radiofrequency ablation in the United States in October of 1997, really beginning in 1998. And it was a huge advancement technologically. We could just put needles through the abdominal wall, laparoscopically, percutaneously, and it opened up a world of opportunities for many patients. I think, unfortunately, we went down a bad road and didn't do maybe all the due diligence we could have done, and I think that maybe has jaded some of our opinions that unfortunately lasts to today. Excuse me. And again, with radiofrequency ablation, with selected patients, we could easily destroy liver lesions and kidney, bone, wherever. And again, very effective when used properly. And when we started looking at some of the long-term survival of patients with liver-only metastases, again, these aren't selected patients. This isn't controlled for chemotherapy. But again, we're getting that 20 to 25% long-term survival treating a systemic disease with a local therapy. Again, fairly remarkable from a cancer point of view. Now, when we look at radiofrequency ablation more carefully and really selected patients with small lesions and look at survival of small lesions being treated with radiofrequency versus resection, and again, these aren't randomized trials, but again, you can see that survival is about the same, and procedure-related complications are much less with ablation versus resection. Now, back in the early day, we did track our data, and this is one of the facts that sticks with everybody's mind, so I'm going to try to get you off this. But when you look at your own data, what we realized is that when we treated lesions greater than 3 centimeters, that the local recurrence rate became increasingly higher, particularly as the lesions got larger. And we did a lot of work in the lab trying to make that better, and we made some advancements. But again, this is something that sticks with everybody. And I want to say that this is data for monopolar radiofrequency ablation, and it really has nothing to do with modern ablation techniques. So then we moved on to microwave. Microwave's been around since the mid-1980s, but really the good microwave systems, the modern microwave systems, if you will, really became available in the beginning of the 2000s in the UK and the United States and other places. And again, I would love to talk all afternoon about microwave physics because it's something I truly love, but different frequencies out there. In the UK, started off with 245, as did Japan. In the US, we started with 915 megahertz. And I just showed this slide to show that the physics of microwave ablation is completely different than it is for monopolar radiofrequency ablation, and one should not compare the two technologies because they are completely different. When it comes to microwave energy, you have a microwave near field. That's defined by the frequency and the antenna design, and everything within that microwave near field is heated through radiation. Therefore, it's not susceptible to thermal or electrical sinks, as is monopolar radiofrequency ablation, which again is one of the reasons that we have high local recurrence rates with radiofrequency ablation. When we did our clinical data and compared directly 915 versus 245, 245 for the same amount of energy applied was about half the time that it takes to do an ablation. So that sort of won out throughout the world. So 915 has gone away, and now we use 245. And currently, we're on the 4th generation of microwave generators. So a new generation comes out about around every 3 years. The dominant frequency used in clinical use is 245 gigahertz. And some of the advantages now, they have multi-probe generators, so we can have multiple antenna going at one time. We have advanced image guidance systems, and we also have planning software to make it easier for the user and more effective and decrease our local recurrence rates. And again, when we do not overlapping zones of ablation, but using multi-antenna array, we can achieve even larger zones of ablation. So again, I think that in most people's minds, we feel that we cannot adequately treat lesions greater than 3 centimeters. And here's just a couple of clinical examples. This is one of my patients with a metastatic colorectal cancer. She had multiple other lesions as well. And we chose to treat her with microwave. And you can see that very effectively, we can completely destroy pretty much what we want. And we can destroy the entire liver if we wanted to. We try not to do that. Sometimes that might be counterproductive. But we try not to knock out more than 1/3 of the liver in one setting. But again, the thought of not being adequately able to treat a lesion greater than 3 centimeters in the modern world is completely false, and we need to get past that. This is just another more recent example of a patient with a large metastatic lesion in the right lobe of the liver. Was that lesion resectable? Yes, but for other reasons, we chose to ablate that. And again, the point of this slide is to demonstrate that we can pretty much microwave any volume of liver that we choose. Okay, and that's a clinical decision based on multiple variables. So I'm only talking about the technology right now. So Aaron Berber from Cleveland Clinic tried to do a comparison, sort of apples to apples, regarding radiofrequency and RF. And you can see with microwave versus radiofrequency that there's significant decreases in OR time, there's a decrease in ablation time, and there's about a half the incidence of local recurrence at the ablation site when using microwave versus radiofrequency. And that's, again, primarily because of the physics involved in the delivery of energy of microwave versus radiofrequency. So superior technology. When we published our clinical outcomes, and I apologize for the busyness of the slide, but this is for a variety of pathologies, but you can see here in the red dotted lines for, again, these are uncontrolled studies. These are observational studies, so all comers, no control for chemotherapy, no control for other therapies. You can see, again, we're having those 5-year survivals of around 25% for colorectal cancers in selected patients in the appropriate context. So nowadays, we do about 97 to 98% of our ablations are done surgically, are done laparoscopically, and certainly I think we can all appreciate that a minimally invasive surgical approach is certainly going to be a benefit to the patient from an OR cost, time, morbidity, complication rate. So a minimally invasive approach laparoscopically is certainly superior to an open approach overall for the patient and for the system. But there are still a couple of other things that we need to factor into this. And if we're going to treat patients with metastatic colorectal cancer with a curative intent, then we have to ask ourselves, what's the best modality of ablation? Should we be doing that percutaneously, or should we be doing that surgically? Well, I think there's a couple other variables that we need to consider that I think are very important. Again, I want to reiterate, if one is trying to treat a patient with a curative intent. And although we have great imaging nowadays, we have great CAT scans and MRIs and PET scans and DOTATOT scans and this scan and that scan, there's still limitations of modern technology. And when we laparoscope patients, unfortunately, this is what we do see on a regular basis when we go in for a resection or ablation, is occult peritoneal metastatic disease. And I would say for metastatic colorectal cancer, realistically, that incidence is probably around 10%. And so again, if you're going to choose an ablation as an approach and you're thinking about percutaneous approach, then again, about 10% of the time you're going to miss metastatic occult disease. So then how could you possibly report data if you don't have adequate staging with laparoscopy? Secondly is the extent of disease within the liver. And I would say very comfortably that the most accurate way to find lesions in the liver, despite all the wonderful imaging we have, is intraoperatively with an ultrasound probe in experienced hands directly on the liver. I have Dr. Hagopian sitting in the front row, so I'm sure she'll agree with that particular comment. So everybody needs to be an expert at intraoperative ultrasound if you're a surgeon. And so when we do evaluate the liver, and obviously this is an extreme example, but again, we operated on this patient not knowing we had all of this in there, that we do find, I would say, in 25 to 35% of the time, there are more lesions within the liver than we can appreciate. So again, if one is choosing a percutaneous approach and you have a 25 to 35% chance of having more disease in the liver that you're not identifying, and you're treating that patient with a curative intent, it would seem to me an inadequate approach. And again, this is probably a little bit more realistic if what you're going to find, because it's hard to miss those big lesions, small multiple lesions. And again, those outcomes are going to be very different if you laparoscope a person versus a percutaneous approach. And then finally, there are technical limitations percutaneously. You can see there's an occult lesion in the liver on the far right of the left lateral aspect of the liver. And again, they were afraid to burn the stomach percutaneously, burn the abdominal wall, and have an incomplete ablation. And these are some of the technical reasons where the outcomes from a local recurrence point of view, or a survival point of view, are much worse percutaneously. And certainly our data, when we publish our data and we look at a percutaneous approach versus a surgical approach, and not only our data, but others, 3, 4, 5 times higher incidence of local recurrence with a percutaneous approach versus an operative approach. So I do want to congratulate the Dutch for really taking on a very aggressive approach, trying to finally answer this question is, what is better, resection or ablation? I'll come to my final comments, but this is a fairly aggressive, ambitious approach, trying to get 300 patients in each arm, trying to stratify the disease by minimal disease, intermediate level disease, and large volume disease, and then stratifying and randomizing to resection versus ablation. That opened, I think, in January of last year. We probably still have a few years to go, and then we look at long-term follow-up. So it'll be a while before this finally gets published, but again, I want to congratulate the authors for taking this on. So my summary is that certainly microwave ablation is definitely more locally effective than radiofrequency ablation, and I think that the traditional limitations of radiofrequency ablation in the modern world are certainly not applicable to microwave ablation. You know, colorectal metastatic disease is a systemic disease, but again, we have those patients, that subgroup of patients with liver-only disease, that can be cured with a local or a local regional therapy, such as resection or ablation. So I do believe that whatever intervention that you offer a patient, whether it be ablation or resection, certainly needs to be taken in the context of a multidisciplinary, multimodal approach. And that just because you're a hammer, not everything is a nail. And so the treatments that we offer have to be put in context. Certainly a minimally invasive approach clearly offers advantages over an open approach. And I also believe when you're treating a patient with curative intent, offers advantages to a percutaneous approach. We can also use microwave to extend resections to get clearance of the liver. And finally, and I know this is supposed to be a debate and an argument, but I personally don't believe that microwave is a competitive technology to resection. I think that it is a complementary technology, and we as hepatobiliary surgeons need to be able to pick and choose which modalities of treatment we offer our patients in the context of their care. So thank you very much.